Welcome to ASA Central Line, the official podcast series of the American Society of Anesthesiologists, edited by Dr. Adam Stryker.
Well, hello and welcome to Central Line. I'm Dr. Adam Stryker, your editor and host. Dr. Primm, editor for Summaries of Emerging Evidence, better known as SEE, is with us again today. And we're going to learn about two items featured in the 41B issue. One relates to cardiopulmonary resuscitation, and the other is about positioning following laparoscopic upper abdominal surgery. Always enjoy hearing about the clinical topics that SEE highlights. So we're happy to have Dr. Primm back on the show. Aaron, welcome back.
Hey, Adam, thanks for having me back. Always a great opportunity to share some more about the C program. So thanks again.
Well, let's delve right into the issues, and we'll talk about the issue of in versus out of hospital cardiac arrest first. Give us some background on this particular topic and explain what factors are associated with less favorable outcomes when you talk about in versus out of hospital cardiac arrest.
Yeah, sure. I mean, I think the easiest thing to do is just set a baseline definition. So what we're talking about of an arrest is the loss of circulation that's going to prompt resuscitation with either chest compressions, defibrillation, or both of those things. In hospital arrests, about 300,000 adults annually experience this, unfortunately. Has a high mortality. The average age is 66 years old. They're 58% men. And the rhythm is not shockable, about 81%. So those are asystole or PEA. 50 to 60% of the time it's cardiac, and 15 to 40% it's respiratory insufficiencies causing this. The survival rate after in-hospital cardiac arrest actually did improve a lot from 2000 to 2010, where it has since plateaued. And it's not completely understood why. There's possibility that some of the interventions from guidelines have actually increased the incidence of ROSC, or the return of spontaneous circulation, but maybe not particular survival. Regardless, only about 25% of patients actually survived a hospital discharge. And then that drops to 10 to 12% in out of hospital arrest. And that's really one of the major differences between in hospital and out of hospital. Of course, where the patient is found out of hospital, if it was witnessed or not, are all factors. But the most strongly associated factors with the outcomes are the presenting rhythm and the duration of the cardiac arrest. Because a shockable rhythm is actually 2 to 3 times higher survival to discharge than a non-shockable rhythm. We want to make sure that there's early initiation of CPR, because that's associated with the best improvements in outcomes for both out and in hospital arrests. And your chance of 30-day survival markedly decreases with the increasing duration of CPR. And part of the problem is that we really don't have any good models to predict. They lack sensitivity or specificity to identify who's actually at risk for this happening in and out of hospital cardiac arrest. There is something called the CAS-free score, which is like the cardiac arrest survival post-resuscitation in hospital score, where the higher score indicates a lower probability of a favorable neurological survival. And there's certain things like the age group, their initial rhythm, the location they're in, the duration of the resuscitation, all go into the score. Unfortunately, the score is not able to accurately identify many patients with a very low or no chance of survival. And so it's really not something that can be used in decisions of withdrawal of care in the hospital setting. Our biggest challenge is deciding when to stop CPR during a cardiac arrest because of the limited guidance we have. And, that's really what the authors were trying to get into in our first study.
I understand there's a study aimed to examine the time-dependent probabilities of favorable outcomes. Can you tell us a little bit about that one and how the researchers tease out the useful information that you were alluding to?
Yeah, this study was from the British Medical Journal by Kubo and colleagues, and it was called The Duration of Cardiopulmonary Resuscitation and Outcomes for Adults with In-Hospital Cardiac Arrest, a retrospective cohort study. Some of the background they give is that the resuscitation efforts are terminated in nearly half of patients after they have an in-hospital cardiac arrest without ROSC. And, raising the question of when clinicians should stop resuscitation efforts, is there anything that they can learn? So their primary objective was to quantify the time-dependent probabilities of favorable outcomes as a function of the duration of CPR among patients pending ROSC. And they wanted to do this at each minute duration while CPR was going on. And the outcomes they wanted to assess were the survival to hospital discharge and favorable functional outcome at hospital discharge. Two distinctions there. They also wanted to look at any differences based on features such as age, the initial rhythm, whether it was witnessed or unwitnessed. And the retrospective study used the Get With the Guidelines Resuscitation Registry, which is a multi-center quality improvement registry of in-hospital cardiac arrests of adults in the U.S. And they included about 350,000 adult patients who had an arrest and received CPR between 2000 and 2021. They did exclude patients that went on ECMO, those that had DNR orders and things of that nature. And the functional outcome at hospital discharge, one of their outcomes, they define that as a cerebral performance category score of 1 or 2. And this is a 5-point scale where 1 is a good cerebral performance and all the way to 5, which represents brain death. So these were the primary objectives of this study.
All right. Well, what did they learn?
So after they ran to the registry and got these patients, they found things that kind of verified what had already been known in some respects. The median age of the patients was 67, more than half were men, and 76% did not have a shockable rhythm. Only 22.6% in the study survived a hospital discharge, and only 15.6% had a favorable functional outcome. So that's not that far off from what was previously known. In the patients that did have ROSC, the median interval between the start of chest compressions and ROSC was 7 minutes. And among patients that didn't have ROSC, that time was 20 minutes. So it makes sense that, longer wait has a lower ROSC. They found that the overall probability of survival to hospital discharge was less than 1% once you reached 39 minutes. And the probability of a favorable functional status was less than 1% at 32 minutes. So it was 39 minutes and 32 minutes. And then on their further analysis, they had better outcomes for patients that were younger than 60, had a witnessed arrest, and had an initial shockable rhythm. So, these are things that logically make sense, but it is interesting how they were able to really quantify where that probability becomes less than 1% of survival during the resuscitation.
So let's put it into clinical context. How do these findings help our resuscitation teams and ultimately our patients?
Well, this is, it's extremely clinically relevant information. And I would imagine that this would help facilitate some shared decision-making in determining whether, further CPR would be beneficial in some of these patients. A longer duration of CPR may be warranted for these specific patient subsets, the younger age, the witness arrest, and so on. And in line with these findings, we have to remember that providers are encouraged to not rely solely on the duration of CPR to determine when to terminate resuscitation. So I think it gives us just a couple more tools in the tool belt to use in these really tough decisions that are made in a crisis that can be really difficult when there's little information that is really out there.
It's incredibly difficult. And the ramifications are so big that even if you have really solid objective evidence, it is hard to make the decisions based on that, just given the ramification. It is obviously difficult to call the end of resuscitation and know that, all right, there's just nothing more we can do, because there's always the thought that there might be a possibility. Maybe if we just do this, maybe if we do a little longer. I don't want to be the one to decide to give up. What do you think about all that? How we all make sense of integrating the objective data with really difficult decisions?
Yes. Oh, certainly. This is something that I really would doubt that someone would be like, you know what? I just read this study, and the second we click the 39 minutes, we're going to call it, right? I think maybe it can just shift our anchor of where we're going to start to have those different conversations. Perhaps this patient does not fit into this category of more favorable outcomes, and we've reached that time. And now maybe the conversation starts in a little bit more earnest. Maybe now people are calling the family, people are getting together everything that they need to make that final call. So again, extremely difficult situation, but I'm glad there's a little bit more evidence out there for people to have.
Right. Yeah. Nobody would expect anyone else to look at a study and say, no, that's it. But yeah, I think it's an interesting dynamic with this particular aspect of clinical care and how the empathy with providers or physicians, any clinician that has to integrate the objective side of things with the subjective side, and it's just an interesting dynamic, and it's a tough one.
Certainly is.
Well, let's turn to the second item that you wanted to discuss with the C program in issue 41B. It relates to optimizing patient position after general anesthesia with respect to early postoperative hypoxemia. If you don't mind, remind our listeners what's known about a semi-recumbent position versus a supine position.
Right off the bat, the part of the hypothesis that the authors have in this paper is that perhaps positioning can be used as some sort of novel strategy to augment post-op hypoxemia in their patients after general anesthesia. And this is where they're coming from. I mean, if we talk about the different positions, I think we all know what supine position is. We have our patients in that position because of simplicity, accessibility to the airway, able to reach the upper extremities, the neck. But some of the downsides can be that, when you are flat on your back, there is a reduction in your FRC, maybe about a liter while awake, and further decreasing another half a liter when you're under an anesthetic. And, patients that are obese with pulmonary disease of advanced age all can have issues with ventilation in the supine position. The semi-recumbent position is where the patient is on their back, but they're elevating the head of the bed 30 to 40 degrees. And that's been shown to increase lung capacity 10 to 15%, increase FRC, improve the range of motion of the diaphragm, all things to help with the lung expansion and gas exchange. And in other areas where it's been helpful, can reduce gastric reflux, and there's some evidence that there's a reduction in the risk of ventilator-associated pneumonias in the ICU. But of course, there's also some disadvantages of having patients in that position during surgery and after. And those could be things like hypotension, venous air embolisms, cerebral ischemia if the tissue is not being perfused properly. So, like anything in medicine, there's risks and benefits. But this was what the authors were looking for, is they could do something with patient positioning to actually affect postoperative hypoxemia.
So a recent trial aimed to shed light on the impact of position during emergence and in the PACU. Talk a little bit about what that trial looked like.
This was a paper from the JAMA Open Network by Wang and colleagues, and I believe it's also in the June issue of the Monitor. It was a single center randomized controlled trial, had 700 adults, to look at postoperative hypoxemia after a laparoscopic upper abdominal surgeries. And these were done under general anesthesia between March of 21 and May of 22. Keep in mind that there were some exclusion criteria like a BMI over 35 and any lung disease. What they did was they randomly assigned to one of three groups that only differed according to patient positioning during anesthesia emergence and then recovery. So they had supine, 15% semi-recumbent, or 30% semi-recumbent. And at the conclusion of the surgery, where they had a mostly standardized anesthetic, the patients were then moved to a stretcher and then placed in the appropriate position based on their group assignment. And that position was actually maintained throughout the entire emergence from anesthesia, extubation, and the PACU stay. So they stayed in that same position through that entire time. They did have routine oxygen administered after extubation, and there was rescue mask ventilation if the oxygen saturation was less than 90% for 1 minute. Additionally, they inserted an arterial line, and that was so that they could get blood gases to get some of these results. The primary outcome for the study was the rate of postoperative hypoxemia, which was defined as an SpO2 below 90 for more than 10 seconds, or a PaO2, FiO2 of less than 300. And the other outcomes they looked at were the time to extubation, the the rate of a severe postoperative hypoxemia, which is, they defined it as an SpO2 under 85 for more than 10 seconds, how often they had to use rescue airway management, like mask ventilation or reintubation, their comfort in the PACU, the length of stay in the PACU, and then any adverse events from the positioning. So these were all the things that they were looking at in this study.
Okay, so it's interesting, the design. Tell us about what they found.
Yeah.
What did they learn?
So after analysis, they concluded that the risk of hypoxemia was lower in the 30-degree semi-recumbent group than either in the 15% group or the supine group. And there was a risk ratio of 0.72 for the 30% compared to the supine. And then on the multiple logistic regression analysis, they also found that to be true, with the odds being much lower in the 30-degree group compared to supine. The severe hypoxemia was also lower in the 30% semi-recumbent group than in the supine group, with a relative risk of 0.59. And the rate of airway rescue management was also lower in the 30-degree semi-recumbent group than in the other groups. There was less coughing in the 30-degree group. Respiratory comfort scores were higher, and PACU length of stay were shorter in the 30% group. So really, all these things favored having them at 30 degrees. They didn't find any differences in extubation time, and there were no position-related adverse events that were observed. So they really kind of underscored that keeping these patients at least at 30 degrees really lowered the rate of this hypoxemia and severe hypoxemia that these patients experienced.
So let's talk about the clinical context of this one. I mean, I think it's fairly evident what this is showing, but talk a little bit about what you'd like to see clinicians get out of this.
Yeah, and like you alluded to earlier, it is a very interesting study design, a very interesting approach, keeping the position stable during that entire postoperative period, even during emergence. And it's something that seems reasonable to implement, but this was a specific surgery with a very specific patient criteria, and so I think that should be kind of kept in mind, that these were laparoscopic upper abdominal surgeries. So, the generalizability may or may not be there depending on when you're implementing the strategy. And also that they excluded, obese patients and those with lung disease, although I would imagine this would also in somewhat help them as
Right.
well.
Mm-hmm.
But, one component that they didn't explicitly discuss is, and I think you could imagine, is all the coordination and communication and kind of process change that would need to occur to have patients remain in that position throughout the entire emergence and recovery period. So they actually took the patients off the OR table onto the stretcher at that angle and then emerged from that angle. And unless everyone, all the staff and faculty and everyone in the recovery room is all on the same page, that could go awry. I think it's amazing that something as simple as just keeping them in a certain position really does have measurable effects. And I could imagine this being part of AROS protocols, part of QI efforts.
Yeah.
If, a department institution wants to go that direction and wants to coordinate that.
Well, or even targeted patients, even if it's not part of a protocol, but, it might lead to, certain technique for certain patients that would really see the benefits and the risks are minimal. But like all good studies, it hopefully leads to further investigation, where, as you alluded to, we can find that it's perhaps more generalizable than just the one surgery.
Yeah, exactly. It would be great if there was more follow-up, and, I think they wanted to pick a certain patient population where they thought this might make a difference, right? Because putting their head up probably helps them be a little more comfortable with upper abdominal surgery, take larger tidal volumes. These are all kind of things they had hypothesized about later on in the paper. And it makes sense. So if there's anything where actual positioning might help in taking deeper breaths, avoiding atelectasis, things like that, it's a possible strategy for sure.
In the study, did they look at if airway interventions were undertaken? Were there any morbidity associated with that or any extra hospitalization associated with that?
Yeah, they did not demonstrate any additional morbidity or mortality or things like that. And I think the rates were pretty low to begin with.
Yeah.
But yeah, they did not see a difference there.
Okay. Well, before I let you go, why don't you give us a little insight into the entire issue of SEE? Are there other topics we should be on the lookout for, or some takeaways that you'd like to highlight?
Of course, I always love to plug the program. Just a little background in case someone doesn't know. SEE, it's a continuing education program. It summarizes over 200 research articles from over 30 journals to try to produce this product that's pertinent to anesthesiology's clinical practice. And each product is worth 60 CMEs per year. So that's this resource that we're putting out there. And, one thing I wanted to highlight from this issue, or at least from, our talk today, is that actually both these studies come from journals that aren't, specifically anesthesia journals. And so I think that's another valuable thing that this program can highlight some of the broad findings in the rest of the medical literature that can really relate to what we're doing and kind of expand the horizons. One other kind of theme for this next issue are a few interesting studies in the OBGYN world. So one item is that a recent study found that 4.5 units per hour of oxytocin infusion was the effective dose to achieve sufficient uterine tone in 90% of patients after a 1 IU bolus and parterians undergoing elective cesarean delivery. So they found that 4.5 was sufficient in 90% of patients. Another study found that 1 in 19 patients become persistent opioid users after vaginal or cesarean delivery, with maternal factors more strongly associated with persistent opioid use compared to birth-related events. And then finally in this theme, there was a systematic review and meta-analysis that showed that women with suspected placenta accreta spectrum disorder prior to having a C-section, prophylactic radiologic interventions were associated with reduced perioperative blood loss and also fewer red blood cell transfusions. So really planning interventions in high-risk patients really did show a difference for these women. So, this is a little bit of an overview of this issue and what the C program can offer everyone.
It's a fantastic program. And give our listeners, the ones that are not familiar, what can they expect for a specific issue in terms of the number of studies or topics that are covered in general?
Yeah, it's a broad range of topics. Some issues have some more than others, but we really do try to follow all of the pertinent topics that come out from the ABA and from the ASA resources. And like I said before, we're hitting over 30 journals a month and really trying to pick out the things that are going to be relevant to people's clinical practice. And we get plenty of feedback every issue about what we did right, maybe what we did wrong, but always overwhelmingly positive. And, we try to tweak it each issue that comes out, get things into the monitor, be on podcasts like this, really try to get the word out for what this program can offer members.
Yeah, again, fantastic program. And this is a great conversation. I always enjoy these conversations. So thanks so much for joining us today.
Adam, it's my pleasure. Thanks again for having me. It was wonderful.
And listeners interested in more about the program can find C or SEE at asahq.org/SEE. Please tune in again next time and take care.
Hi, this is Dr. Alex Arriaga with the ASA Patient Safety Editorial Board. Teamwork is a hallmark of patient safety. There are some fundamental themes pertaining to teamwork that can enable safer care in the operating room. Communication is relevant for interactions both between anesthesiology colleagues and interprofessionally across disciplines. Leadership can include principles such as role clarity, delegation of tasks, and decision-making. Situational awareness is a concept that includes perception of the information in one's environment, comprehension of its relevance, and anticipation of its implications. Safety checklists, which have been designed for both routine and emergency perioperative scenarios, can foster principles of teamwork while also reviewing processes of care. Teamwork is a multifaceted concept that can be leveraged towards the safer care of patients perioperatively and beyond.
For more patient safety content, visit asahq.org/patient safety. You can't read everything, so C does it for you. Learn what the specialty is learning on your own time. C is available now with insights from journals from around the world. Try a sample question at asahq.org/SEE. Subscribe to Central Line today, wherever you get your podcasts, or visit asahq.org/podcasts for more.